Namaskar, Hare Krishna. I'm here with you to discuss a interesting case which we have been able to witness in ICU. And in order to discuss this case, we have the team with us where we are going to unfold the case scenario as we have gone through. I will give you the brief idea about the case, that what case we have gone through. Now, this is a young patient with us who is around 24 years old, and she is 29 weeks period of gestation. The pregnant lady, she had APH because of the placenta previa. She had just intermittent spurts of the bleeding, for which she got hospitalized to the outside hospital. She remained in the hospital for almost 2 weeks plus, where she was otherwise being managed in terms of the anemia, for which she received the transfusion. But thereafter, this lady was shifted to us mainly because of the patient was having a features of systemic inflammatory response syndrome. In short, the patient was getting unwell to the outside setup, and that's why the patient herself and the family had seek the opinion to visit us. Now, when this patient was received by us, the patient was in a difficult situation, and I will give you the brief idea that what exactly the patient has gone through. And the patient was first attended by Dr. Abhinandan, and who is better than Dr. Abhinandan to help us in understanding that what he has witnessed as a first point of a medical contact. So, Dr. Abhinandan, I would like to know your opinion and the facts which you have witnessed in this case.
Thank you, sir. Uh, we received the patients a couple of days back. Actually, she came in the night, and when I came in the morning, I saw that the patient was on
Abhi,
oxygen.
keep it over there so that you, yeah, yeah,
Am I audible? Okay.
yeah.
So the patient was oxygen dependent. She was getting high flow oxygen through nasal prongs. So that was at around 10 liters per minute.
So, 10
And
liters was the oxygen the patient was receiving at the
yes,
time
sir.
when you received the patient.
Yes, sir.
And I think it was the off day, it was basically the Sunday
It
when you
was
had to
Sunday.
visit for this patient,
Right,
right?
sir. Right, sir.
Okay, so what you felt about the patients at the
Yes, sir.
first point of a
She
medical
looked
contact?
very distressed. She
Very
had her
distressed.
respiratory rate was very high, sir. It was around 50, 55 at that time.
So, she was having a high minute
High
ventilation.
minute ventilation. And basically, her ABG also showed that she was having hypoxia. And they had said that she had fever on two occasions previously. At that time, her BP was also a little bit on the lower side, sir. So she was showing some signs of inflammation, definitely. But we didn't have her reports as such at that time. So instinctively to prevent the hypoxia further, and since she was pregnant, so I put her on HFNO for that time.
High flow nasal
Yes, sir.
cannula.
And I was presuming that the tachycardia, tachypnea, everything was going on because of the hypoxia. And actually, it settled down the tachycardia at that time. The respiratory rate came down to around 25, 28. So I decided to give it a trial. And then, sir, I saw that when I did the lung ultrasound, I found out that there were some signs of pneumonitis or query pulmonary overload. I was trying to decide between the two. When I saw the cardiac thing, sir, I did not feel like she had any cardiomyopathy at that time. So volume overload, I did not feel that she had any. And secondly, sir, transfusion at that time they had received only one blood transfusion. So it
So,
was
one blood
unlikely that
she has been transfused.
maybe that was also one thing that some trolley and all we did not consider at that
We
time,
did
sir,
not
because
consider.
very only one blood
It was a
transfusion was
packed
there.
blood cells which the
Yes, sir.
patient has received.
And
So, I'm sorry, but just to reframe that, what I can understand from what you have given,
so
you have given a large piece of information, very interesting case, which you have been able to demonstrate for us at the first point of a medical contact. The patient was tachypnic.
sir,
The patient was having a respiratory failure. The
sir,
patient was tachycardic.
yes, sir,
The patient was also hypotensive.
yes, sir,
And on the basis of these parameters,
sir,
you said my patient was having a systemic inflammatory response syndrome. And you
awesome.
were able to demonstrate on the basis of your screening test that the patient was having Shred sign,
Yes, sir.
which was there in the left
Yes, sir.
lower zone of the lung,
Yes, sir.
suggestive of pneumonia.
Yes, sir.
Okay, that's great. So now I would like to know from Dr. Ankit. So, Dr. Ankit, what do you think this patient was having, and what we did in this case to begin as a treatment? And then I would like to know from Dr. Aarti that where we could have done better, or do you feel that we were happy with the overall management, or do you have any difference of thoughts? So first I would like to know from you, Dr. Ankit, that what we have done as the initial resuscitation provider.
Thank you, Dr. Manish. So, as this case was
You
received
can
by
apply it here. You can apply it here.
as this case was received by Dr. Abhinanda, so very nicely he has managed this case. During in the initial part of the management, as you told, this patient was having systematic inflammatory response syndrome. So to reduce the work of breathing, so initially he has managed, or we have, the ICU team has managed with the high frequency nasal cannula and some intermittent NIV. So just to reduce the work of breathing, as because she was a pregnant lady, 29 weeks pregnant. So this is a challenging case because we are dealing with the two lives.
Two lives.
So being patient, as the physiology also get changed during the pregnancy, so hyperdynamic circulation, having surge response, patient having gravid uterus, so leading, keeping all this thing in mind, and to what the initial part of the management, the work of breathing, which was supported by the non-invasive non-invasive things, ventilation. So this helped the patient in refraining from the intubation as well.
Okay.
Meanwhile, taking care of all this, because gravid uterus, we have placed
I will come to the gravid uterus, but I will come to the gravid uterus, but just for the sake of the listeners, to help them to simplify the things, we know that what Dr. Abhinandan has seen. Now I would like to reframe my question: what treatment the patient has received, and we will discuss about the physiological changes which will happen in the pregnancy and how they are going to change your line of the treatment, line of the assessment. But first, I want to know what treatment the patient has received, which you have been able to see, as far as the treatment from the intensive
so
care
re-
team is concerned.
yeah. So related to the treatment part, so first the
So let's do it in
airway
airway. Yes,
airway.
exactly.
So
So in airway, what we have done?
we have supported the work of breathing with the non-invasive
So
ventilation.
non-invasive ventilation to improve the work of
Work of
breathing,
breathing, yes.
and we chose in this case switching between the NIV
NIV and
and
high
HFNC,
HFNC.
right?
Yes, yes.
Okay, that's great. And then in the breathing, obviously we
We
supported with the
supported the
support.
breathing, yes, yes.
And what about the circulation?
As circulation, patient was resuscitated and it was supported with low dose fluid. So she was
So,
responded to the fluid
so
challenge.
basically, she was fluid responsive,
Yeah.
and that is why the patient received some aliquots
Aliquots
of
of
fluid boluses,
boluses.
and thereafter she was on continuous maintenance
maintenance
fluids.
fluid.
So that is one part.
Along with this,
Yeah.
and as the patient was stayed in, as Dr. Abhinandan has taken very nice and detailed history, that patient has previous hospitalization and it was almost 16 days of stay, right? If I am correct. So he stayed almost 15 days plus in before other hospital. So related to this, when patient was having a surge response, so antibiotic was also escalated along with this because patient was received on ceftriaxone, right? So along with this resuscitation, antibiotics were also escalated simultaneously within a span of within the limit of hours
So
only.
that's great. So I understand. Thank you, Dr. Ankit, for giving us a comprehensive review about what the patient has received, and it looks like that we were following
Regarding
the
the sepsis bundles for
yes. So we were following the protocols which has been highlighted by Surviving Sepsis campaign.
Yes, yes,
So the first half bundles which were supposed to do the 3 hours bundles, by and large they were followed.
yes,
Right. So Aarti, my next question to you. Can I have a mic, please?
Yeah.
So Aarti, just keep it with you. So do you think these kind of a cases, in other words, what do you think is the working diagnosis to begin with? One, what working diagnosis you're carrying for this patient, and on the basis of working diagnosis, what should be the line of treatment? One, two, three, four, five, six. What do you
Yes,
think?
sir. Yes, sir. Yes, sir. Thank you for Dr. Manish, sir, and Dr.
No, no,
Ankit, sir.
thank you.
Yes,
Now I
sir.
just want you to go
Uh,
ahead.
yes, sir.
Okay.
So that working diagnosis, as per to investigation and X-rays, showed that is maybe that trolley, because that Dr.
Okay, so
Abhinandan
first
is right.
differential was
Yes,
trolley.
sir. Yes,
Okay.
first trolley. But when I goes to the investigation, so that counts is raised is 24,000 that time, and transaminitis was there. So maybe that is a hospital acquired pneumonia.
Okay,
Can
so
be
you're saying
considered
hospital
for that,
pneumonia because Dr. Abhi
because
Nandan was able to demonstrate the shred sign.
shade
There was a
sign B
patch.
lines was there, or
B
that
lines, B
opacities,
lines, Aarti, may not be very specific,
ubiquitous.
but
Yes,
if you're
yes,
able to show the shred sign,
yes,
the
sir.
fractal sign, which is very specific for pneumonia,
Yeah.
and moreover, when the patient present to us, she was, as Dr. Ankit also has highlighted, she has been there in the hospital for 2 weeks plus,
Yes, sir.
and in the hospital when the patient is stay for a long, especially when the patient has received transfusion, fluids, and multiple, the
Yes, sir.
antibiotics, they become a risk factors for hospital-acquired
Yes,
infections.
sir. Because she is a pregnant
Yes.
lady, and that immunity rate compromise
No,
is
no, no. I would like to differ in this case. Pregnancy is not a state of immunodeficiency. Pregnancy is a state of immuno
compromise.
different physiological response.
Okay.
So they're not having, they have a different physiological response. They, at any point of time, they're not having immunodeficiency. So that
Okay.
is one where we would like to differ from you. But nevertheless, I think the point here is that we were dealing with, by and large, the hospital-acquired infection,
Yes, sir.
where the source of infection was hospital-acquired pneumonia,
Pneumonia.
and she was coming to us as a full-blown case of
Yes.
systemic inflammatory response syndrome, sepsis, maybe early sepsis, not had reached to the degree of septic shock, right?
And
Okay.
she admitted with the complaint of burning micturition also, because Foley's catheterization was done in previous hospitalization, sir.
So,
So one,
okay. So I would like to know from you, Abhinandan, and then I will discuss with my, the youngest team members who are there with us, Aksa, and Akshara. Aksa and Akshara. Okay, I will ask you some questions also. So here I would like to know from you, Abhinandan, uh, if your patient is having a hardware devices like tubes, Foley's catheter, central venous catheters, or any other hardware device,
Sure.
what does it help you understand? Is this history or is this findings in the examination, they're important for us
Yes, sir.
when we are receiving the patients from
Yes, sir.
outside?
Yes, sir.
In what sense does it going to help me in planning the treatment or any strategy for them?
So definitely, initially, if I find that the patient has any indwelling kind of a catheter or maybe ET tube or anything, I would always consider that they could be a source of infection for whatever the patient is. If the patient is in sepsis, we are suspecting. So cultures need to be sent from them and well. And generally, our protocol also is that we change it on arrival, mostly ET tubes or anything from outside, and we send cultures for that, sir. If that is
Okay.
what you're implying.
So thank you. I think you have answered, the question. So the patient who is having any hardware devices from outside hospital, they becomes specifically the source of colonization, and eventually this colonization becomes a source for infection.
Infection, sir.
And that is why any devices, be it the central line or police catheter, there are three major hospital-acquired infection which we are always worried of. One is COTI,
COTI,
the second is CLAPSI,
CLAPSI,
and third is VAP.
VAP.
So there are three things, as a physician, as an intensive care specialist, we should be always talking about.
Sure.
Now I want Dr. Ankit. So I need from you, Dr. Ankit. Let's say, what do you think the surviving sepsis campaign guidelines endorse for these kind of cases? What is their endorsement when a patient who is suspected as a case of a sepsis? She came to us as a sepsis, right? She was not having a full-blown features of septic shock. So what do you think should have been done as far as the recent most guidelines is considered?
So
And I
as-
would also like, Mr. Pankaj, I would like Mr. Anil to be here because I want to discuss some points from Anil as well. Right.
So, according to the recent guidelines of surviving sepsis campaign, so as the initially we told the airway, breathing, and circulation has been managed. So, according to sepsis guidelines, we have 1 hour bundle, 3 hour bundles. So, within a span of 1 hour bundles, we have to resuscitate the patient, and within a 1 hour span and till the 3 hours, we have to send
Okay.
the cultures and antibiotics should be received.
So excellent. I think the first point. So let me go step by step with
Yes,
you,
yes,
Dr. Ankit. Let's say if I'm receiving a patient who is having a sepsis, what should be my protocol as far as sending the blood culture, the lactate, the fluid resuscitation, the antibiotics, and the reassessment of lactate? So I've given you 5 points to structure them. What do you think when I see the patient who is having a sepsis? What should I do for them as far as the fluid therapy is considered?
As soon as the fluid therapy is concerned, we should resuscitate the patient with the 30 ml per kg body weight.
So 30 mils per kg in a patient who is having a septic shock,
Septic shock, yes.
or if the patient has sepsis-induced hypoperfusion,
Yes, yes, yes.
which means either there is a fall in the urine output, or there is a rise in the lactate, and sepsis-induced hypotension,
Yes.
where if you're giving them 30 mils per kg, you expect them to respond to the fluid bolus.
Yes, yes.
But it may not be desirable in a patient who is otherwise just having a sepsis, but may not be having a sepsis-induced hypoperfusion or septic shock.
Yes, yes.
Now, this patient was having sepsis-induced hypotension,
Hypotension, yes.
and that is the reason why, and hypoperfusion. That's why the patient received I
And
think
she
at least
responded to the
15,
fluid.
and she responded. Very
Yes,
good.
yes.
So that is one. Now, what about the second thing? Taking the blood cultures and sending the lactate for them.
Yes, immediately we have to take the ABG sample
Excellent.
just to see the lactate levels,
Yes.
and simultaneously we have to catheterize the patient just to
Okay.
see the urine output,
Okay. Very
just to
good.
see the perfusion markers, urine output,
Excellent.
and capillary filling time.
Excellent. Excellent. I think you have narrated all the beautiful points. Measure the capillary filling time in them. If it is beyond more than
3
3 seconds,
seconds, yes.
you should be worried. Secondly, you talked about the urine output. You talked about the serum
Lactate.
lactate, arterial lactate, which is also important in them. So beautifully expressed, Dr. Ankit. Thank you. And what about the culture strategy for them?
Simultaneously, we have to send two pair of blood cultures.
So two pair of blood culture. What do you mean by paired blood culture in this scenario?
One we have to take it from the central axis, and central, or like two sides we have to
Two
take.
sides. So two
Two sides
anatomical
is
sites,
important.
two
Two
anatomical
anatomical sites is
sites,
important.
and paired aerobic and anaerobic.
Aerobic and
Right.
anaerobic cultures.
And do you think blood culture is important, Abhinandan? Why? So just keep on shuttling this device because we
Sorry,
want
sir.
this audio to be very
My
clear.
miss. So basically, it is important that before changing or escalating or starting the antibiotics, the cultures need to be sent. It has been recommended by the Sabine
No, I agree
Yeah.
that before giving antibiotic, first dose of antibiotic,
So,
we have to draw the culture.
yes, sir.
My question, which I want to, which I need a clarity that why you think blood culture is important.
So because they will help us in the antibiotic stewardship eventually.
nice.
Basically, what we
Excellent.
are in cases where needed, we will escalate or maybe de-escalate according to the cultures and according to the organisms.
Very
We
good.
have to be
So I
specific.
think Abhinandan has beautifully expressed that you start when you receive the patient, you start them on broad spectrum antimicrobial therapy, and depending upon the cultures isolates,
So,
you narrow down to specific antibiotic to
yes,
that specific agent,
yes, sir.
to that specific etiology which is leading to sepsis or a septic shock.
True, sir.
So it's a part of your antibiotic stewardship protocol. For example, broadly speaking, we start them on gram negative, gram positive,
Broad
maybe
spectrum.
anaerobes. But later on, when we discover, let's say the patient is having a E. coli,
So,
which is sensitive to carbapenems,
Carbapenems.
so we have to stop gram positive.
True,
We
sir.
have to stop anaerobic. We have to be just ensuring my patient is receiving the gram negative.
Gram negative
So does it make sense?
antimicrobials. Yes,
So
sir.
thank you. And now the next question, which I was talking about, he said blood cultures. Now, what about the importance of antibiotics in this strategy, which we discussed in the morning round also? I am having a suspicion of sepsis. What do you think? How aggressively, how intensively, how meticulously, and how intuitively we should decide about the antibiotic? How
Yes.
fast we have to be
So
when
at
we are
this,
dealing with
this
the patient?
particular point of time, we were very much sure that we are dealing with a case of sepsis or really be advanced sepsis going to be ahead. So in this case, we have sent the cultures, and as we were sure that the patient was having all hardware devices, she was having stay in our previous hospital, so she was a risk factor of MDR XDR infection.
Very good. So the patient who is
So
coming from outside
outside with
hospital,
yeah.
so especially beyond 48 hours of his stay,
Yes.
is a risk factor for MDR XDR.
Yes, yes.
Okay, that's great.
What
What is it?
patient was initially on ceftriaxone, so considering that all this point which I have explained before, so we have escalated the antibiotics to piperacillin tazobactam, which is a good cover for the
That's good point.
cover
So
for the
let's
MDR.
say, Dr. Ankit, you know that your patient is having a, or you missed that my patient is having a risk factor for MDR XDR, and we started the patient on third generation cephalosporins, or maybe a fourth generation cephalosporins, beta lactams, which may not be appropriate to MDR XDR likely organism in your given patient who is having a case of sepsis or a septic shock. Does it going to affect the patient outcome? Or maybe Abhinandan can also answer. Aarti, anybody, if you would feel.
Your question is if,
So let me just redo my question. Your patient is high likelihood for MDR XDR organism,
yes, yes,
but you failed to capture this information, and you started the patient on the simple antibiotics like second or third generation cephalosporins like ceftriaxone or maybe cefepime, right? Which is not appropriate according to the uh, MDR XDR pattern in your hospital. Now, a wrong antibiotic for the given agent, does it going to affect the patient outcome? And in case yes, how does it going to affect?
definitely if we are not giving the, because as we used to say appropriate antibiotic, appropriate dose.
Yes.
And
So I want you to be
appropriate,
loud on this point.
so this
Appropriate antibiotic
antibiotic, appropriate dose, appropriate route should be
should be given.
considered.
So in case if we don't do, what will happen?
Sir, like you said, sir, any delay in antibiotic is going to push the patient to
Yes.
adverse outcome.
So I would just add whatever
As
you.
according to the guidelines, every hour delay
Yes.
in antibiotic will increase the mortality of 7%.
7%. Now this is what I wanted to share. If you don't use the right antibiotic at the right time in the right dose for a given infection, you will increase the mortality burden by 7.6% for each hour delay. So if your patient has a delay of around, let's say, 10 hours, which happens in the developing setups, you can expect 76% chances that your patient is going to die, right? So now, because Mr. Anil is with us, and obviously Anil has supported us in this patient care. Can I have a mic,
Yes,
please?
yes.
So Anil, I want you to hold this mic. So अनिल, मैं आपसे ये जानना चाहूँगा कि अगर पेशेंट में प्रेगनेंसी था, जैसे ये पेशेंट आपने देखा, ये प्रेग्नेंट पेशेंट था,
जी सर।
आपको क्या लगता है कि प्रेग्नेंट पेशेंट की केयर में क्या डिफरेंट होता है एक नॉर्मल पेशेंट के कंपैरिजन में? अगर उसको साथ में इन्फेक्शन है तो हमें इसमें क्या डिफरेंस आपने किया जो आपको लग रहा है इसमें कि?
थैंक यू सर।
हाँ जी
सर, बेसिकली ऐसे केसेस में सर पेशेंट को हम जैसे असेस करते हैं, जैसे कि पेशेंट अगर अगर कार्डियक में जैसे कि टैकीकार्डिया है, टैकीप्निया है या कुछ सर रेस्पिरेटरी डिस्ट्रेस है,
हाँ।
तो पेशेंट को सबसे पहले असेसमेंट करते टाइम पे पेशेंट को पोजीशन प्रोवाइड कराएंगे,
हाँ।
अच्छे से पोजीशन
तो
प्रोवाइड
इसमें ना
करेंगे।
मैं थोड़ा ये पूछना चाहूंगा अनिल, क्योंकि ये इंपॉर्टेंट है और आपने शायद हमसे शेयर भी किया था मॉर्निंग में,
यस सर
कि अगर एक प्रेग्नेंट पेशेंट है
जी जी जी।
और उसको हमने सीधा लेटाया हुआ
ओके
है
सर।
और उसको हम रिससिटेट कर रहे हैं,
जी,
आपको
जी।
क्या लगता है ये एक नर्सिंग प्रोटोकॉल में क्या होना चाहिए? प्रेग्नेंट पेशेंट को सुपाइन पोजीशन में इनका रिससिटेशन करना चाहिए या कुछ और पोजीशन में करना चाहिए?
नो
और
सर,
करना चाहिए तो
सुपाइन
क्यों?
पोजीशन में सर ऑब्वियसली हाइपोटेंसिव होता है पेशेंट को।
वेरी गुड।
प्रेगनेंसी पेशेंट को जो आईवीसीज है उसमें प्रेशर रहता है सर,
तो
तो उसकी वजह से सर पेशेंट को हाइपोटेंसिव होता है, उसको बोलते
Very
हैं
good.
सर सुपाइन हाइपोटेंसिव सिंड्रोम। जैसे
Very
कि
good,
आपने
very
सर
good.
आपने
Very
सुबह
good, अनिल।
मुझे एक्सप्लेन किया था सर।
हाँ।
तो सर इसमें पेशेंट को लेटरल पोजीशन प्रोवाइड करनी चाहिए अपन लोगों को,
हाँ।
बेसिक केयर देनी चाहिए पेशेंट को, लाइन ट्यूबिंग सब सिक्योर रहना चाहिए सर
बहुत
पेशेंट को।
अच्छा। नहीं, थैंक यू अनिल। आई थिंक
you,
आपने
sir.
जो सबसे इंपॉर्टेंट पॉइंट बताया कि प्रेग्नेंट पेशेंट अगर हमें कभी भी मिले, उसका बेसिक रिससिटेशन हैज टू बी डन in the left lateral decubitus, and if you cannot keep the patient in lateral decubitus, then at least give left uterine displacement by 30 to 45 degrees. है ना? I think, thank you Anil, and that is why we wanted to highlight this point in our presentation series, that how the pregnant patient, they are different. Anybody who would like to share, especially Aksha and Akshara, that why what are the basic physiological changes which happen in a pregnant patient which are different from the patients who are non-pregnant? कुछ बताना चाहोगे
Yes, sir.
अक्सा? या प्लीज।
Sir, heart rate usually increases in
वेरी
a
गुड, वेरी
patient
गुड
who is
अक्षा। तो मैं
pregnant.
थोड़ा सा बस आपके साथ इंटरेक्ट करूंगा। सो अक्सा, व्हाट यू आर सेइंग कि हार्ट रेट इनमें थोड़ा सा, दे हैव अ हायर बेसलाइन,
Higher, yeah.
which means that the criteria for the SIRS is different.
Hmm.
So normally, if your heart rate is more than 100,
100, yeah.
you take it as a cutoff that my patient might be having a
Tachycardia,
systemic
yeah.
inflammatory tachycardia.
Yeah,
Yes.
tachycardia.
But for pregnant patient, 100 is normal for them.
Yeah.
And this typically happens because of the hormonal changes which happen in them. So you don't take it as abnormal. Anything else?
Sir, blood pressure is
Very good.
also
So the
increased.
blood pressure actually reduced by 5 to 10 millimeter of mercury, both in the systolic and diastolic.
Yes, sir.
So the patient may look hypotensive, especially in a full-term gravid uterus, like 20 weeks plus. And you may feel my patient could be hypotensive because of the sepsis. So when a pregnant patient comes with a sepsis, your interpretation of septic shock has to be very, very clear. Because what may look shock may not be shock when it comes to the physiology, which changes in a pregnant patient. Anything else?
Sir, venous return and
So venous return. What about you, Akshara?
renal system,
Yeah, tell me what happens in renal system.
it will decrease.
So you can hold it and speak, please. Speak in this mic.
Renal system will
Renal
decrease.
system. So what happens to renal system? So in fact, the GFR increases in them. GFR increases in them, right? So you may find the creatinine goes down. The creatinine, which is around 1.2, actually for a pregnant patient, maybe actually 1 could be normal for them. But before this, there are some significant changes which happen. One, the most important, the plasma volume expand in a pregnant patients by 1 to 1.5 liter by the end of 20 weeks, which means they have extra amount of fluid, which allow them to compensate when the patient goes through the sepsis or a trauma. They have extra amount of volume. So they may not be symptomatic early. Why? Because they have an extra buffering within them, which may not be, like, for example, if they're getting depleted by 1 liter, they may not be just having any changes at all because they have this extra amount of plasma volume, right? The second thing which is different from them, we have talked about the blood pressure. Now, ABG is very different in a pregnant patient. The pH of 7.35 to 45, which is normal for us, in a pregnant patient, they are alkalotic. So their 7.45 is normal for them. So if you find my patient is alkalotic, which otherwise looks abnormal for us, for a pregnant patient, you have to readjust this figure. The second thing is that, which is very, very important, the PaCO2, because they are hyperventilating. They are hyperventilating. In a pregnant patients, the PaCO2 normal for them is 30 to 35, while for a normal, healthy, non-pregnant patient is around 40, right? So they are alkalotic, right? And this happens as a basic part of their physiology. Because they are alkalotic respiratory alkalosis, the bicarbonate is become less in them as a physiological change. So the normal bicarbonate for them is around 17 to 25, which otherwise may sounds to be acidemia for a non-pregnant patient, right? That is important. Now these are the changes which happens in your ABG. Now why they're important? Because if you find a pregnant patient who is having a PaCO2 of 45, which may sounds to be normal for a non-pregnant patient, could be a sign of ventilatory failure when it comes to the pregnant patients, and they may actually need assisted ventilation. Did you understand? So these are important. And last, if you talk about the lungs changes, the tidal volume is actually, what happens to tidal volume anywhere?
Tidal volume is probably the same or increase.
Yes, it is. Yes, so tidal volume is in fact is on the high side, and that's mainly happens because of AP expansion of the chest. The gravid uterus is pushed more capsular, so the AP, the anterior posterior diameter, has to expand. So the tidal volume is in fact is on the higher side for them. The minute ventilation is on the higher side for them, but they have a tendency, as you have said, for increased desaturation. Why? Because the closing capacity of the smaller alveoli is much higher than the FRC. So the smaller alveoli, they tend to collapse faster with a lot of air trapping which happens with them. So I think we have summarized, and our patient has got resuscitated well, and now the patient is in fact doing well. So I would like to make the people see that how do the patient is placed now. But before that, Aarti, would you like to summarize this case, what we have gone through, maybe in a 30 seconds or
Yes.
something?
So she's admitted on 9th of
Diagnosis,
yes,
diagnosis, treatment,
diag-
and outcome.
yes, sir. The diagnosis is, sir, APH induced with
APH
first,
with
then
hospital
hospital
acquired
acquired pneumonia,
pneumonia and
then
sepsis,
sepsis with
sepsis, right?
Yes, sir.
And coming to you with the sepsis,
Yes, sir.
resuscitated on the
With the
line of
fluid on the
surviving
line of
sepsis campaign
treatment.
guidelines,
Yes, sir.
1 hour bundle, 3 hour bundle,
Yes.
with the outcome where the patient is now off from any vasopressors.
vasopressor
She's
and
clinically quite
stable.
well. And now we would like you to visit the patients to understand that how do the patient is placed. Unfortunately, we don't have a video which we could have shared with you when she was there with us at the first point of a medical contact. So it is there with us, but not we can show it in this video. And I would like you to see the patients, and then it will help you in understanding that how the patient outcome changes when you have these kind of cases, right? So can we visit to the patient? हाँ जी, कैसे हो बेटा? ठीक हो बेटा? एक बारी आपको ना वीडियो पे रिकॉर्ड कर रहे हैं, आप ये बताओ कि कैसा आपको कितना आराम आया, क्या हुआ, पहले क्या प्रॉब्लम आ रही थी, बताइए। थोड़ा तेज बोलो, वो वेयर डू वी हैव अ माइक, बोलो, बताओ।
सांस में दिक्कत आ रही है, अब तो आराम है बहुत।
कितना आराम है? 100 पैसे में से कितना आराम आ गया होगा बेटा?
50%।
50% का आराम है पिछले 2 दिन में?
हाँ, रात से ज्यादा आराम है।
रात से ज्यादा आराम है।
कल ज्यादा हो रहा है,
कल ज्यादा हो रहा था। पहले सांस फूल रहा था और बुखार आ रहा था। सांस बहुत तेज आ रहा था।
कल
और
आया, सुबह ना आया बुखार भी।
बुखार भी नहीं आया
ना।
अब भूख लग रही है?
हाँ, भूख भी सही लग रही है।
ठीक है, ठीक है, बस कृष्णा को याद करते रहो, ठीक रहेगा। ठीक है बेटा, ठीक। सो काशीराम कौन है? ओह अच्छा ठीक है, काशीराम को याद करो, ठीक है यार। सलाम वालेकुम। ठीक है ठीक है। So this is how, you know, we wanted to make you understand that, you know, you have a smiling patient with you. Now this can only happen when you are available at the right time as the antibiotics, at the right place, and in the right doses. This is what the team is all about, ICU Care. Thank you. Namaskar.